As Julie mentioned, my name is Candace Boutel. I'm also with Inspire Sheboygan County. And we just want to thank our sponsors for today's session and all of our healthcare sessions, the NEW Northeast Wisconsin AHEC Group, Area Healthcare Education Center. And then we have the Milwaukee AHEC Group as well that are sponsoring these sessions so that they can be open to anyone in the state. And as you can see, we have a lot of people on the call here. We have a lot of people that will be viewing the session after. So thank you very much for tuning into this. So I would like to introduce Megan Cummings, as Julie did before. She is the PACS Administrator and CTMRI Team Lead. And Megan is going to start by telling us a little bit about her career path and also the different types of imaging that you might find within the area of diagnostics. So as you're listening into that, you can ask for more clarification in the questions. Any questions that you have can be typed into the chat. And once we've gone through Megan's presentation, we will be getting to some of those questions. So Megan, please go ahead.
As Candace mentioned, I am working out of Holy Family Memorial, which is in Manitowoc, Wisconsin. So I'll tell you a little bit about our facility and our diagnostic imaging department, and those all can be adapted to any diagnostic imaging department. So for those in the Milwaukee area especially, those facilities are a lot bigger, so you have a lot of potential growth and development in those areas and can expand your career a little bit more and specialize a little bit more. So I'll try to touch on some of those things when I get to them. So I started off as an x-ray tech at LTC, is the technical college I went to school for. So it's a 2-year degree right out of high school. I then cross-trained into MRI at working for Shared Medical, which is a mobile MRI company. And then 2 years almost into that, then I came to Holy Family to work at their MRI department. And then after I was here for a few years, I like to keep my knowledge base expanding, and I wanted to grow in my career. So I ended up going back for my bachelor's degree through Concordia University. And so they took my LTC credits and bumped me up to a fast track program. And I did actually business management. So I figured I could have a lot of different career potential in the hospital if I wanted to get out of diagnostic imaging with having business management. But honestly, I love imaging. It's kind of fun. So you have my screen up there with my little x-ray people there. And I like to kind of think of us in imaging as little fancy photographers. Instead of looking on the outside of the body and just seeing a picture of somebody, you're actually looking inside the body to find those pictures and those disease processes possibly and see what's going on. And so it's kind of fun to be those eyes and ears of a doctor that's going to be making those diagnoses. Now, one caveat with imaging is we do not diagnose patients when we're taking the pictures. We cannot give results. And we are not, like I said, a doctor that's qualified in making that diagnosis and giving those results. So that's my one caveat when it comes to imaging here. There are a couple different areas in diagnostic imaging that you can work in. One is where you start off is in x-ray school, radiologic technologist. It's usually a radiography program. Most tech colleges have a program. You can do a bachelor's degree through, I believe UW-Madison has a bachelor's program, and there's a couple other facilities that team up. Bellin in Green Bay has a radiography program, and then they partner with UWGB to get your bachelor's degree, but you certainly don't have to do that. An associate's degree is required now to practice radiology, but a bachelor's degree is not required. So from there, easy transition can be into mammography, which I'll talk about after we talk about x-ray. You can also do CT and MRI. Nuclear medicine and sonography are part of diagnostic imaging, but they have a very different career path. You do not, in most cases, do not have a radiography background for those modalities. You start off at that program level. For nuclear medicine, it has its very own program out at La Crosse, UW La Crosse, and ultrasound has different technical schools that they can go to, but you don't have to start off in x-ray. For mammography, CT, and MRI, you have to start off in x-ray. There are no direct programs for those type of modalities at this point that I'm aware of, at least. So let's talk about radiology. So radiology does use ionizing radiation to take our pictures. It kind of goes through the body and creates an image on what we used to use was film, just like in a camera film. Now it's more of a cassette type for digital radiography, and there's no film or chemicals really anymore to develop that film. There was when I was in x-ray school, for the record. Salaries can vary depending on where you're working. In Madison, for instance, since we have a lot of people from the Madison area, you'll probably start off higher with those higher facility hospitals that take in a lot more critical patients, but anywhere from $40,000 to $55,000 around there. And that is pretty much for, I would say, all of the modalities if you don't have your license or your registry for that modality. But as you get credentialed by taking exams, and demonstrating that you have a knowledge base in that modality, pay scale kind of goes up, and everyone is a little different. Every hospital is a little different. Every setting is a little different. Because with x-ray, you can certainly work at a clinic and take x-rays there and not have chaos, I should say, of a hospital where you can be going in all different directions. You can do outpatients, ER, and surgery patients at the hospital and inpatients, but in a clinic, you're going to have those walker-talker patients. So salary might be a little bit lower in those kind of settings. Regardless, across diagnostic imaging, you need to be a people-oriented person. You need to know how to talk to people, sometimes be able to handle blood, body fluids, and difficult situations. Most of the time when people are coming to imaging, they're sick or something is wrong with them and they need an answer. And so some people are very upset by that. They're scared. And so having to help those patients through that is a must. It's definitely a criteria to be people-oriented in imaging, as in all healthcare pretty much. So this is what one of our x-ray rooms looks like at Holy Family. And in this particular one, we have 2 x-ray units. This is one that we would point at either the table or the wall, and it would take images on this cassette type thing here to get our pictures. And that would be just a straight regular x-ray. This one is called a fluoro unit, which we would do live motion kind of pictures of the body. And I'll kind of show you a picture of that. I don't have like a clip of that one though, but we'll show you a picture of that. Again, radiation, this is where the x-ray, the radiation is coming from, is those 2 units. Now in this situation, and when a patient's not having their exam, there is no radiation being emitted. It's completely safe to be in the room. But when we turn on the x-ray for that little bit, that's when the radiation is there. Again, most of the time, those x-rays are very low dose radiation. It's not something to be really concerned about. And in fact, the most frequent x-ray ever taken is a chest x-ray, where they're looking at the lungs and the heart, seeing maybe a bronchitis or a pneumonia, trying to rule out different processes. And actually, at Holy Family here, we take over 7,000 chest x-rays every year. They equate the radiation level for a chest x-ray to be the same as doing continental flight from LA to New York, with the same amount of radiation you would get in the atmosphere is about what we would get from a chest x-ray. Very, very minimal. With x-ray, we almost always take 2 views. We take a front view and we take a side view, and we want to see how things look in those different comparison features. So here we got the chest x-ray, but where it's really important too is when you're looking at a broken bone. For instance, this one is a wrist, and you take this picture here and you can definitely see the displacement of the bone and the fracture. But then we take that side picture because without this, you wouldn't really realize how far back it's displaced. Similarly, if we only took this view, you wouldn't see how those bones are displaced that way. So usually 2 pictures. Then this is an example of how I mentioned in the fluoro, where we're watching the body under the fluoro live x-ray. What we'll have patients do sometimes is, for different reasons, various different reasons, they would drink what's called barium, and that's that white stuff in here. And that helps us look at the internal organs of the body with x-ray, because typically with x-ray, you see more, I'll go back here, you see more of the shades of gray, you can see the bone, but you don't see a lot of definition in the soft tissue. So you wouldn't see the definition of the muscles, tendons, and ligaments. So you wouldn't see that definition of the bowel and internal organs as well. So they'll drink the contrast and we'll watch it in the stomach, and then they'll take pictures at different intervals to see how it's kind of working through the body and working through the small bowel and until it gets to the large bowel. And sometimes they'll take pictures of the large bowel depending on what they're looking for and how far they're following through. So this one you can see when we had film like this, we would write on there what interval it was taken at. So this one is taken at a 3-hour and 15-minute interval. A lot of scans don't always go to that. A lot of pictures are usually pretty quick, but in this particular case, this particular exam takes a while, and it has been kind of replaced with CT a little bit more now, but they will still do that. So a kind of fun thing in X-ray too is being able to watch patients as their care changes and what they might be going through. So you'll see if you work in a clinic, like in an orthopedic clinic, for instance, patients have X-rays every single time they come. And you'll be able to see like if their joint is maybe deteriorating and if they're getting really painful and have a lot of different things going on with arthritis, they might have surgery. And then we'll see them after their surgery evaluating that prosthesis. This is for a joint replacement and seeing how that changed. And it's kind of fun to see things like before and after and how things can change if somebody gets, it's kind of morbid in a way, if somebody gets a fracture and how they fixed it. And it's just really kind of neat to watch them fix the body and take those pictures as we go. You might see this in a clinic setting, but you'll definitely see it in a hospital setting as well.
Lexi was asking, and I was wondering if this maybe had to do with the flora x-ray you were talking about. Lexi was asking, why would you take a moving x-ray versus a still image x-ray?
So the moving x-ray is going to be watching as the contrast comes through. So they'll actually watch it from the esophagus all the way down, from the mouth all the way down into the stomach, and how your esophagus is functioning and how the tongue functions and how the epiglottis functions in order to get that barium all the way through. But we wouldn't see that without the moving x-ray, without that flora part. If you just took a static picture, you're going to see one moment in time, and you want to be able to see how that body function is, not just the picture of the body, if that helps.
Yes, excellent. And then Mary was wondering, does it matter what side you would take the picture from, the left or the right, when you do that second image?
Typically, we do the left side, especially with chest x-rays. Let me get back there. With chest x-rays, we would do the left side because of how the heart is oriented. And that's something that you learn when you're in x-ray school. We typically always do the left side unless the patient can't for some reason. But I mean, normally if the patient can't move enough, it's more just a matter of positioning them and somehow. But every body part is different. We actually, like for an ankle, you would take it, it's called medial to lateral. So you'd always have the outside of the foot down. It really kind of depends on what body part you're looking at and what you want closest to the film because of magnification factors that can come into play.
Excellent, excellent. And then there was maybe one more that related, I think, to the one where you're talking about the orthopedic. What kind of metal is the prosthetics made of? Or I'm thinking when they are doing knees and hips and things like that.
So most of the time it's made of titanium. That is the most common one, titanium screws, simply because they don't rust. Surgical stainless steel is also sometimes used for implants. But for prosthetics like this, it would usually be titanium. And those are safe in different modalities to scan in, like for MRI, for instance. MRI, we'll get to that, but it's a high-powered magnetic field. And so certain metals can't go into that area. So they would use, in joint replacements especially, a metal that is not magnetic so the patients can continue to have those exams safely.
Wonderful. Those were mostly the x-ray ones. I know we've got more, but I bet you'll be covering some of that as you move forward. Thank you.
Sounds good. All right, so we'll go to mammography, and I won't touch a whole lot on this, but basically mammography is taking screening mammograms, x-ray pictures of breast tissues, looking for possible cancers. Breast cancer it has a very high death rate. I almost want to say it can be very dangerous for women. So you want to catch it in its earliest stages. So they do recommend women 40 years and older have a screening mammogram every year so that they can catch that at the earliest stages. So this is an example of a mammogram here. We can see a little suspicious area, maybe some calcification in there. And what they would do from there is either maybe a biopsy, maybe an ultrasound first, sometimes even an MRI, to help rule out what's going on here and figure out what's going on and help make that diagnosis. The doctors would be the ones performing the biopsy, but the mammographers, the technologists that are trained in doing mammography, would be the ones assisting the doctor with those biopsies. So I'll go over into CT, computerized tomography. So in this modality, we use x-rays as well, but instead of taking a straight on picture, a front and then a side picture, it's called cross-sectional pictures. And I'll show you some pictures that hopefully help understand that. Again, when they have patients that come to CT, they're usually pretty sick. And so again, being able to handle those unpleasant illnesses, being able to help patients get through their illness a little bit, it's a fairly short duration that we see them in x-ray, sometimes like a 5-minute chest x-ray. CT might be like 10 to 15 minutes between the time of explaining the test and getting all the way through it. So it's a short duration, but you still need to be able to help those patients and hold your composure around those type of things. With CT and MRI, of course, too, we need to know a little bit more about anatomy and physiology, because the way we take our pictures, you see a lot more of the anatomy than you do on just a straight x-ray. So you need to know location of those body parts in a little bit different manner. And hopefully that'll show on the images that I have. So this is an example of a CT scanner. And what happens is, instead of having that one pointed at a wall like we had in x-ray, the x-ray tube is actually within the CT scanner itself. And what it does is it spins really, really fast. I can't even do my mouse as fast as what it spins around the body here. And the table moves in and out to take our pictures. And the x-ray just stays kind of within this donut, kind of, so to speak, and takes those pictures all the way around the body. So what I mean by cross-sectional is, if you imagine this patient, think of him as like a loaf of bread. And what we're doing is, our pictures are almost like we're cutting that loaf of bread and holding it on end so we can see inside the body a little bit better. Like this. This is, again, that cross-sectional picture. So we're looking at anatomy similarly, but different, I guess, in a way, because we have to know that this is the heart more towards the front of the body. The lungs are more towards the back. The spine is towards the back. That liver kind of lives in the middle, and see where all of those different organs are to be able to know if something's truly abnormal or not normal, or abnormal or normal, because that might depend on how we image things. So while we don't diagnose, we still have to know the differences about what's normal and not normal, so that we can take the pictures a little differently for the doctor if they need us to. For instance, on this one, and when we're doing a picture, we're looking at a whole section of the body, and we're looking at it from top to bottom. So we might start off in the neck, right below the chin here, and go all the way down through the abdomen pelvis. So on this particular one, we've got a neck here, and there's a big mass here. And we won't necessarily know what type of mass it is just by this. That's what the doctors especially are for, and they're trained in looking at how things enhance differently. And I say enhance because we do give a contrast injection through an IV. This particular one has it, and I can tell that because in these circular objects, that's vessels, and it's very bright compared to the soft tissue here. Again, this one too, this is in the heart, and you can see how bright that contrast is, and then here in the aorta. And having to know those body parts in those locations is important, again, like I said, to know that this isn't right. This one's probably a little obvious, but sometimes it's very subtle, and you want to make sure that on your pictures, you have everything visualized properly and you're through the anatomy properly. You don't want to cut off part of the liver if that liver might have a mass somewhere. Like I mentioned, we might go through the whole body here. So in this particular one, we're always going to take the images in what's called an axial point of view and this point of view. But on abdomen, we're looking at the little base of the lungs all the way through the abdomen pelvis to see what's going on with that body part. And this is where, how I kind of mentioned with the fluoro and with that small bowel image of the 3 hours, where CT is kind of taken over a little bit, because you can see in the body a lot more detail than you can on that other picture. But for certain disease processes where they're watching it go through the body at the different intervals, they still will need to do those tests. So they're not obsolete by any means, but they are still necessary, and it all depends on what we're looking for. So on this particular one, I pointed out here that the patient has an appendicitis, and that's a very common CT that they'll do if the patient has a fever, right lower quadrant pain, and we're trying to figure out what's going on. And then all of a sudden they got a nice angry, we call it angry appendix that needs to come out. All right, so we'll go into MRI, and this is where I'm a technologist of, so I actually scan an MRI. So again, I can go on this forever if I need to. I'll try to keep it condensed for you guys, okay? MRI is part of diagnostic imaging, but I had kind of mentioned a little bit, it's very different. And it's different because we use a magnet. We don't use ionizing radiation at all. There's no damaging radiation in any way, shape, or form when it comes to MRI. There's just a magnetic field and a radio frequency pulse. So with MRI, what a lot of people associate it with is a loud jackhammering type noise. That's just how we get our pictures, because we don't use the radiation. The con of MRI is they take longer. So I said that x-ray might take 5 minutes by the time we position you in both planes. CT might take 10 to 15 minutes, depending on what body part they're looking at and what they have to do, sometimes a little bit longer. But MRI could take easily 30, 45 minutes, depending on what we're looking at. Again, some are quick, like 10, 15, 20 minutes, but most of them are around the half an hour mark. And that whole time you have to hold still, because one movement will displace and mess up our entire images, and we'll have to repeat things, which then keeps you in there longer. So again, that's where those difficult situations, those being able to get people through their exam comes into play. Sometimes that sense of humor is really important because patients are really nervous and they want to know what's going on. And so just being able to help them get through this one milestone of getting this test done can make all the difference. And that's where humor, where they had talked about, can be real important. So it is kind of fun having fun with your coworkers and doing all that stuff, but helping the patients get through their test is important too. So this is what our MRI scanner looks like at Holy Family. And it looks like that donut of CT, but there is nothing moving inside of here around the body. There are like plates that we call gradients that are enclosed here, but this whole big thing is one big magnet. And then the radio frequency pulse is that loud noise that is applied to show the hydrogen levels differently. So with that, I mentioned that with X-ray, when it's off and it's perfectly safe to be in the room because there's no radiation at that time, MRI is very different because that magnet never turns off. It is a superconductive magnet, which means it is very strong and very powerful. And I think it's like 30,000 times the magnetic field of the Earth in strength. And this is a 1.5 Tesla, and they make them up to 7 Tesla at other research facilities. In Madison, that area, they definitely have 1.5s. They also probably have 3 Tesla. And the pros are all dependent on which one you have, is depending on what we're looking for. If there's implants in the body, like I said, I can go on forever about MRI. With that, MRI has its dangers. Because of that magnetic field, it will suck metal into that scanner because that's the nature of magnetic properties. It wants to attract that metal to it and suck it into it. So it can be dangerous if you bring certain metals in the body. So that's where the titanium implant in the hip is important, because it doesn't have that magnetic component on it that's going to draw that in onto the patient. It's going to remain being very safe. There are plenty of implants that are safe. Certain coils, clips, and things for aneurysms are safe, but there are plenty of ones of the same clips or similar clips for aneurysms that are not safe. So we have to take very detailed questions and get a very good knowledge base of what our patients have in their body to make sure it's safe for them to have the scan. There have been plenty of instances of patients getting hurt because of metal being brought in the room, and also technologists getting hurt because of that metal brought in the room when it wasn't supposed to be. Most scanners nowadays, of course, are locked down where they have double entry doors so that things like that don't happen and patients and technologists don't get hurt. But again, kind of like CT, we take cross-sectional images. In CT, the big difference is they take that one plane, that axial plane, that side view looking in towards the body, and then they reformat it to that frontal view that we saw on that abdomen pelvis. In MRI, we're going to take those pictures straight like that in that plane. So for instance, this is called a sagittal, the side view of the head, and we're going to take it on this coronal, and it's going to be like cutting slices through the head this way. And then similarly, where this is a front view, a coronal view, we're going to take it going front to back or back to front on this sagittal view. Then we're also going to take pictures going top to bottom. And the reason why we do that, and all of these are a slightly different sequence, we call it, to make up one exam. And what it does is we look at the hydrogen differently. We have certain parameters that we're taught to use, and it reflects hydrogen differently and water molecules differently. So on this particular one, we'll see fluid is dark, but on this one, fluid is bright. And this is a very special sequence called the diffusion so that we can see strokes really well. And of course, I happen to have a patient that has a really bad stroke on here, so you can point that out. We are not making this diagnosis, but usually once you're in the field for quite a while, you tend to know what you're looking at. And that's where it's important to know those differences though, again, because if I see something like this, I might call the doctor and say, hey, I see this, take a look at it, tell me what else you want, because depending on what we see, it might be different than our normal protocol. He might tell me, oh, I want contrast for this, and then we have to do an IV injection of contrast. Or he might tell me, oh, do an additional MRA, which is an angiogram of the head, because I want to see what's affecting the vessels that might be causing that stroke. So you have to have really good communication with your doctors. And you have to really know what you're looking at to know what's normal or abnormal. This is a head, of course. So this is showing the neurological component that MRI is really great for, but they're also very good for that soft tissue and those ligaments and tendons that you don't typically see on x-rays. So they'll come over into MRI and we'll look at their knee for a possible ACL tear, which your ACL is here, your PCL. looking at meniscus, trying to find tears and what's causing pain for the patients. Of course, like knee patients and shoulders with rotator cuff issues, those patients are in pain, but they're usually not like violently, I shouldn't say violently, but severely ill where they're going to throw up on your scanner or something like that. But that can happen in CT because a lot of times when we're looking at the abdomen and pelvis, you know, they're sick, they've been throwing up or something that we want to see what's going on. And so there's a chance of that patient being sick on your table. But an MRI, it's a lot less likely because we are not having them drink anything or anything like that. But they are in pain and you need to try to get them comfortable. All right, so we'll move on to nuclear medicine. Nuclear medicine is in diagnostic imaging as well, of course, but it is different yet in that instead of having an X-ray machine take the pictures and emit the radiation, we're making the patient radioactive. Again, a low dose, it's not going to do long-term damage to the body, but it's still, we're making your body radioactive. And they'll do that so that we can see different organs and how they function and how they uptake that radiation. Different body parts on how they uptake the radiation will depend on what kind of disease process they have going on. Sometimes they'll swallow it, sometimes they'll inhale it, but most of the time they get injected with an IV radioactive material. With nuclear medicine though, they have a 4-year degree program at La Crosse. So they do not have to have a radiology background. They do not have to start as a tech like you do in CT and MRI and mammography. You have to be an X-ray tech first. They have a program dedicated just to nuclear medicine. And the only school in Wisconsin right now is UW La Crosse. And again, it's a 4-year degree, very, very based on chemistry and physics with them and radioactive properties, of course, because we're making the body radioactive. So if you have any interest in that, this is a very unique field. And there are not a lot of nuclear medicine techs out of there. That's a good field to go into. We actually just had a nuclear medicine tech here that actually unfortunately just left, and he was a great guy, but he's going to medical school now. So they have a really high knowledge of the anatomy, physiology, and of course, then they can expand their career from there. So this is an example of a bone scan in nuclear medicine. And in this particular one, the patient was given a radioactive material and they let it kind of percolate, we say. So it sits in the body after the injection for maybe 3 hours to get it through the body and let the body like distribute it through the entire body before we take our pictures. So we look at the whole body in this case. See, we see the skull all the way down to the toes, and we're looking for areas that pull in that radioactive material. So this is the same type of bone scan here, and you can see this area here is the patient's hip. And this is a blown up kind of view showing that, hey, in this hip, something's going on. We don't like that. Now, you might say, hey, what's going on there? That's a really dark spot. And it is, but that's the bladder. And so when you get injected with any type of contrast material, whether it be radiation from nuclear medicine or our contrast in CT or MRI, it gets filtered out through the urinary tract system. So it comes out when you go to the bathroom. That's how your body filters it out. So with regards to a bone scan like this, the bladder is always going to be pretty dark just because it's filtering out that radiation. So this is a front view. And then again, like I mentioned, we take side views or different views. So this is the back, and it does really matter having the patient on the front or the back so that we can see how it looks, because on this particular one, there's that same hip, but flipped over because they're on their backside, or we're looking at the back view. We can see how that hip is kind of like that, but you can also see now on this one, how the SI joint is enhancing, that there's something going on in that SI joint here. But when looking at that front view, we don't see it as well. So that's where those multiple views do come into play in nuclear medicine as well. Right, so we'll move on to sonographies. So again, this is yet again a different type of modality. We use no radiation, similar to MRI, but they use sound waves to look at the body and look at organs. And once again, this is another field that physiology is really important, how the body functions. And they take some still images, yes, but a lot of times they're looking at the body as it's moving to take those pictures. So this is an ultrasound machine. And what they do is these are called probes here, and they'll use those probes with a little bit of gel. And the gel is kind of, think of it the same consistency as like a hair gel, but it's not as sticky. And they'll put that on the body as a conductor and then use those probes to take the pictures. And the images then appear on the screen. and they will turn the probes different directions in order to get a different picture and get a different, that side view, like we're talking about in x-rays, the two views, angle them differently, front or up or down, just to get a different view of the body, depending on what they're looking at. So of course, what a lot of people associate sonography is with little babies, on pregnant women taking pictures of the baby. And what they'll do is they'll make sure that the brain looks like it's developing properly, and you'll be able to see the little nose and lips. Sometimes you'll be able to see the baby swallow. You see that the spine is developing. You'll see that heartbeats. Now, granted, this is just a still picture, but you can still evaluate all of those things. But again, how I kind of mentioned in sonography, we look at moving pictures more. So for instance, we'll watch the body as it functions. So this is a clip of a heart, and they're watching the heart beat. And then these color pictures are actually blood flow. And the blue is like a venous flow, and then the red is like an arterial flow. And you're watching it as it's going through the heart chambers and how that blood flow is. And then of course, like down here, you can kind of see the heart rate. So they'll a lot more look at that functionality, very sonographer dependent on getting those images. And then they work very closely with the radiologist on what they're seeing, what the measurements are, to get an accurate diagnosis for those patients. And then I did kind of mention when we talked about mammography that sometimes those patients will have a different exam, either an ultrasound like this, or sometimes an MRI or a biopsy. And they'll do that in ultrasound as well. They'll follow that patient from that mammography to have that ultrasound done, and they'll help do biopsies as well with the radiologist. They do biopsies as well in CT, depending on where the best modality is for the image will depend on where they do the biopsy. So it could be under x-ray, it could be under ultrasound, could be a mammography, could be in CT. They do have MRI guided biopsies, although we don't do those here at Holy Family. But at a facility in Madison or Green Bay, they will definitely do MRI guided biopsy. Some of the bigger facilities will do that, but we tend to not do them as much. With that, I'm sure you have lots of questions for me. Like I said, I can pretty much talk forever. So.
Well, that's fantastic to really dive into each of the different types of imaging. I want to go back to a few things. So you talked at the beginning, you made the point that you take the pictures, but you do not diagnose, you do not tell that to the patient. Can you talk more about that? One student asked, so you many times do notice that something might be wrong. Mm-hmm. How do you kind of keep your composure, your demeanor during that time?
That is probably one of the most difficult parts of the job. It's very hard. I don't know how to explain it. You just have to find that stoic face, that game face of pretending like you don't know. And there are patients that are kind of like, come on, you know what you're seeing. And you just have to be like, I'm sorry, I'm not the doctor. I don't make the diagnosis. You'll have to wait for that diagnosis from your doctor. We just can't give those results. And that is one of the hardest part of the job.
Mm-hmm. And that covers a couple questions, because they definitely were talking about challenges. Who decides what pictures are taken? Do you kind of know what needs to be done? Is that completely directed from a physician? How does that work?
I'll answer this twofold, because which type of modality that is used will depend on what they're looking for. A family medicine doctor, internal medicine doctor, any pretty much doctor has some knowledge base of what is going to show things better for the most part, but they do have a pretty decent relationship with the radiologist that they can call them up and ask them, or the American College of Radiology, the ACR, is a lot of times our governing body, and they have different criteria that this test is better than this one for whatever reason. Now, when you're in the modality, when you're in like MRI, for instance, we have certain sequences that we run regardless. It's called our protocol. And the protocol is really dependent, again, on what we're looking for. If it's for a brain for MS, or if it's for a brain for a cancer follow-up, or if it's for a brain looking at the pituitary specifically, will all depend on what protocol we use. And the radiologist typically determines those protocols. And we have 3 radiologists at Holy Family, so the 3 of them kind of make a general saying, this is what we want our protocol to be. And then when we see some of those things, like that stroke, that would be pretty straightforward. That stroke one actually would have been a pretty straightforward protocol. But when we're not expecting to see some things, like if we're doing a regular MRI of the brain for maybe just a headache, and all of a sudden we see something that may resemble that stroke, or we see something that might resemble an aneurysm, or something that might resemble a mass, that we're like, ooh, this doesn't look good. And that's when we call the radiologist and say, hey, what do you got everything you need? What else do you want from me? Most of the time, like I said, it's protocol based and we can just run our protocol and know what we're doing, and not have to vary from it. But that's where it's important to know those differences, to be like, ooh. And then sometimes what I like to do too, I'll see something. Well, I know that this certain sequence is going to show it better. Like I know if I see a brain that looks like it has an MS plaque, I will know that a sagittal flare, sorry, that's MRI term, will show this plaque better, and it'll show if the patient has MS better if I'm seeing something. So I'll run those extra sequences my own, and most radiologists have no problem with that because they are trusting you to see those things and make those decisions. And then if you have questions, then you call them. So you have some liberties with that when you know what you're really doing and what you're looking at. So that's where those anatomy and physiology, different disease processes are important to know. But again, you're not making those decisions. So it's more important not to know what that disease process might be, as much as that it's not right. And what can I do to get that picture better?
Students early on were asking, as you were going through the MRI, is there a weight limit for an MRI?
Yes, there is a weight limit for MRI. And if you kind of notice on the picture, the scanner sizes between CT and MRI are different. CT has a bigger bore, we call it, and MRI has a smaller bore because of the magnetic field. They're starting to come out with bigger bores in MRI, but like our weight limit at Holy Family is 440 pounds. The CT scanner weight limit is like that particular picture of that one is 500 pounds. But honestly, if you look at the dimensions of that scanner and it's a little deceiving because it's a picture, the bore on that MRI scanner is 60 centimeters in diameter. So 60 centimeters around. Our weight limit's 440, but that doesn't mean somebody that's 400 pounds is going to fit into that scanner. A lot of times, depending on what body part we're looking at, so if we have a shorter, stockier person that's 300 pounds, they still might not fit into that scanner if we're trying to look at their abdomen, or if we're trying to look at their neck and shoulders. If they're just too broad shouldered, they just might not fit. So they do have different scanners that can accommodate that. They're starting to have bigger bore scanners that are 70 centimeters, the same dimension as a CT scanner, or they have what's called an open MRI, which instead of being the circle, it has a top and a bottom plate. The downside to the top and the bottom plate is that it's not as strong of a magnet. They can't get the magnetic field as high as one of the round scanners. So it's called a closed magnet. They just can't get it as high. So unfortunately, it just doesn't take as good of pictures. Sometimes some picture is better than no picture. So yeah, so there's a whole bunch of complications with open MRIs, but it does get a picture if they need it, and they can go up to much higher weight limits. All of the scanners, all of the tables, even an X-ray, have some type of weight limit. The only one I guess would be ultrasound doesn't, because you're on a regular cart for the most part. They don't have really a weight restriction when they're using the probe on the body. But even nuclear medicine would have a weight limit on their tables.
Wonderful. I'm going to change gears a little bit. We have about 10 minutes left. Students, being that a lot of these students are middle school, high school, some college age, they're wondering what made you decide to go into diagnostic imaging and specifically MRI?
For me in high school, I wanted to do healthcare. I didn't know what I wanted to do in healthcare. That was kind of the problem. So after talking to some family members, and one of them said to me, he's like, if I could do it all over again, I would be a radiologist. And I'm like, okay, what does a radiologist do? And then I figured out what a radiologist is. They're the doctors that make the diagnosis. And I'm like, ooh, I was kind of afraid to go to medical school. Like I was intimidated by, 10 years of schooling and whatnot, getting your pre-med and then medical school and then specializing in radiology. I was like, ooh, I don't know if I want to do that. I don't know if I like that thought of going to med school. But I wanted to do something in healthcare. And I'm like, I learned more about what radiology was. I did some job shadows and found out, like I said, you're a fancy photographer taking these pictures internally of the body. So I went and did a job shadow. When you do a job shadow at different facilities, they'll get you in all the modalities. So you can see every single one of them and get an idea of what they're doing. I remember my first job shadow was actually here at Holy Family when I was in high school. And I went into the MRI department and I saw a knee MRI, just like my pictures that I showed you. And it was the coolest thing to me to be able to see the muscles and tendons and ligaments. I'm like, he's showing me the ACL on this knee. And I'm like, oh my God, you can see that? He's like, yeah, you can totally see. And then there's a tear, and then you can see how it coils up and it, whatever. And it was just so fascinating to me to see the body that in depth. For me, that was it. I'm like, this is what I want to do. I just went for it. And I did x-ray school because I knew that that's what I had to do. And x-ray school was fun. Don't get me wrong. It was fun and I liked it. There was nothing wrong with it, but I couldn't shake that I liked MRI that much. And so when the opportunity came right out of school for me to get a job in MRI, and they're willing to take students, they actually like taking students right after x-ray school because you're already in that learning mode. So we have to switch your gears a little bit into the MRI physics portion of it versus x-ray physics of it. But it's actually, you're already in that mode. So they were like eager to snap up new students, and I jumped right on board. I've never looked back since. Now, I did decide to go for my bachelor's degree. I wanted to further my career a little bit more. And then now I'm the PACS administrator. So unfortunately, I don't scan as much, and I do miss that because that interaction with the patients, when you're in healthcare, that's like what you thrive on, is just meeting people and making their day sometimes, and just getting them through the test and just being like, I did this today. And you feel great. And it really gives you that self-satisfaction of taking care of somebody. So now I do PACS, which is more, I handle more of the IT side of things, and our archiving system that stores all of that. And what I like about that too is my day is always different. And it was the same thing in MRI. My day is always different. I will see a different scan on every patient, and the anatomy, yes, it's similar. It's all the same as for everybody, but how it looks might be different, and how the disease process is different. You never know what you're going to see on a film until you see it. That's also what I loved about imaging, is like every patient is different. One of the nice parts about it, this is going to sound really bad, I'm sorry, but you have very short intervals with his patients. So you see many patients throughout the day, where if you're a nurse on the floor, you're taking care of the same patients usually throughout the day. If you're in the clinic, you're getting a constant revolving door of patients too. But it was really fascinating to me with imaging to be able to take that time slot of just that few moments in time with that patient, and then you turn around and you do it all over again with the next patient. And you don't linger on 8 hours on the same patient and going back and forth and those kind of things. There's nothing wrong with that. Nurses are amazing. Please know that they are absolutely amazing. I have worked on the floor a couple times with the nurses, and I so appreciate what they do, but it also makes me appreciate my imaging world too.
Yeah, in addition to that, talking about your day-to-day like that and how you would see many different patients, other than the scanning, what are some other things you would be doing on a day-to-day basis?
So in MRI and in CT, we do, pretty much everybody does this. We would be looking up patients in between when we're not scanning. There's usually always 2 technologists on, especially in MRI, for safety reasons. And we're looking up the patient history. What's coming our way? What kind of implants does this patient have? And if they have an implant, then we have to call facilities looking for operative reports, or if they have outside imaging notated on their order, like they had an MRI 5 years ago at a different facility, we'll be calling those facilities, getting those images in so that the radiologist has a comparison, because how something looked 5 years ago might not be how it looks today, and they want to see how things have evolved as well. So we'll be calling for those previous, we'll be getting them in, storing them to our system, looking up operative reports, looking up implants and MRI especially. CT, they're going to be looking up all those patients. With CT, lab levels are very critical with their contrast that they use. They need to have kidney function at a certain level, and we do an MRI as well. So making sure the patient has recent lab work or scheduling them for their lab work, looking at orders to make sure we're doing the right test for the right reasons. So if a doctor orders a CT for a lumbar spine for back pain, but the patient doesn't have any contraindications saying that they can't have an MRI, we're the ones who would be like, well, hold up, an MRI is a much better test. We should really change this to an MRI. And then we'll confirm it with the radiologist. We'll call the doctor's office. We'll call pre-auth, get it all changed. We're constantly looking at our schedule and making sure we're doing the right things for our patients. So that's what we do outside of scanning, and it fills up our day.
Yeah, oh, I bet. Excellent. And is there, you mentioned that in nuclear medicine, there's definitely, there's not a lot of people going into that field necessarily. There's one program in the state. What about any of these fields? Is it a growing field? Is there a lot of opportunities for employment if students were to pursue it?
I would say yes, especially in bigger facilities like Madison, Green Bay, Milwaukee, for sure. There is there's always somebody looking for tech. There's the clinical settings, there's hospital settings, there's whatever that you can get into. And there's always a demand for that, especially sonographers. That's a big field too. X-ray is a big field. CT and MRI, they go back and forth. It all depends on training levels and what's kind of going on. Everybody's hospital needs are a little bit different. One thing that I didn't mention, if I have a few minutes here yet, a lot of times, like at Holy Family here, we do like day shift work. So we do like 6:30, 7 o'clock to like 4 o'clock. But then after that, we're on call, and then we're available on call if somebody needs us, and they have to call us in, and we get paid for call. To do that. But at bigger hospitals, like in Milwaukee for sure, I think even in Green Bay, they have some of them, they have those positions staffed around the clock. So like CT and MRI, they run all night long. So it really depends on where you're at. And as the need for those imaging develop, those imaging modalities develop, and more people are getting MRIs or CTs instead of whatever, then they hire more techs to do those overnight works. So there's always a demand in imaging.
Excellent. That's really helpful. And lastly, Megan, if you want to just tell us, if somebody's thinking about going into this field, what advice do you have for them? What could they be doing early on to determine if this career is right for them?
In high school, for sure, anatomy, biology classes, chemistry, and physics are going to be important. You can always do them in college as well. I did. Medical terminology is very important as well. I took chemistry. I missed it kind of in my senior year, so I ended up doing it at the college level outside of high school. But those kind of classes are going to be very important. Going to those job shadows when you can is going to be real important, so you can know which modality you have the biggest interest in. Because like I kind of mentioned, nuclear medicine and ultrasound have their own schooling path. So you don't want to, I don't want to say waste your time, but you don't want to get all involved in the X-ray program if ultrasound is where you really want to be, or if nuclear medicine is where you really want to be. You want to go straight for that career path. So I don't think, unfortunately, just showing a PowerPoint and images is like, it's a good idea to see what we see, but really doing that job shadow and seeing the environment, and maybe even sitting in some pictures as they're taking them, is really going to show you more about the career and hopefully show you how much you love it, just like me. So
awesome. That is so fantastic. You've shared so much great information today with our students and our audience. Thank you very much for your time.
welcome.
And students, thank you for joining us today.